we have a terrific panel to address something that should be something of a national scandal, and that is that American kids' health outcomes are substantially worse than elsewhere in the OECD. And not only are they substantially worse, but the gap is increasing rather than diminishing. So when I began writing about this maybe a decade ago, there was a study indicating that child mortality rates in the US were about 58% higher than in our peer countries. And last year there was a excellent study published in JAMA, the Journal of the American Medical Association, indicating that American kids are now 80% more likely to die by age 19 than kids in other OECD countries. And this is not nature, this is our choice. These are our policies. So let me start, and Nadine Burke, you've done so much work in healthcare and healthcare policy, and I first got to know you because of your work on ACEs, on adverse childhood experiences, and the way that they affect outcomes. So tell me a little bit about the ACEs and to what extent they not only help explain why we do so poorly, but also offer us an opportunity to move in for treatment.
Thank you. I think many folks are familiar with the research on adverse childhood experiences. That was research done by the CDC and Kaiser Permanente that looked at 10 categories of adversity in childhood and found, which broadly were in categories of abuse, neglect, or having a parent or caregiver who was struggling with mental health, substance dependence, violence at home, et cetera. And what they found was that, number one, that these things are incredibly common. The latest data from the CDC shows about 2/3 of Americans have experienced at least one, and 1 in 6 Americans have experienced 4 or more. And the other thing that they found was that there was a dose-response relationship between these ACEs and adverse physical, mental, and behavioral health outcomes across the lifetime. So, for example, an individual with 4 more ACEs, their risk of developing depression is around 5 times greater than someone without these exposures. The risk of developing substance dependence is between 7 and 10 times greater. Their risk of developing heart disease is about double, asthma, double, et cetera. And it's associated with 9 of the 10 leading cause of death in the US. And fundamentally, what that science tells us is that our experiences and our environments shape our biology, right? So since that study was published almost 40 years ago now, there's been an explosion of research to help us better understand how our experiences during childhood kind of get under our skin and shape our biology. And a couple of things are clear. We know that experiences of adversity are can impact and put our health at risk. And we also know that safe, stable, and nurturing relationships and environments are protective and healing. And so when we see the data, for example, from the JAMA study, one of the things that's really challenging and concerning to me, particularly as I was in the role of California Surgeon General during the COVID pandemic, what we saw was a huge stress on families, on parents and caregivers' ability to provide those safe, stable, and nurturing relationships and environments. We saw many kids lose access to those protective factors and supports throughout the community. And we saw, between 2019 and 2021, we saw the data that child and youth depression and anxiety doubled globally, right? That's not because twice as many kids had a genetic predisposition. It's because there was a dramatic shift in our environment that then was manifest in physical, mental, and behavioral health outcomes. And what that indicates for us is that, I like to say infrastructure is love at scale. What we put into place in terms of our infrastructure, number one, to support families, to support parents and caregivers to deliver those protective factors, and to augment environmental sources of protective factors throughout the community, for our educators, our community-based organizations, all of the above. And also to do what the science shows us, which is that early detection and early intervention allows us to take advantage of the high level of plasticity, biological plasticity in children to improve outcomes. And that is what we did in California when we launched the ACEs Aware initiative. That's, we supported early detection, early intervention, and then investments in networks of care across the state. And it's something that we need sustained investment in that work, and we need to be augmenting this work across the country.
More broadly, I've got to say that as a non-Californian, I have to take my hat off to California for the degree to which the state has become something of a laboratory for social policy innovation in ways that the rest of the country can learn from. And one of the reasons in the JAMA study that that kids in the U.S. are substantially more likely to die is gun violence. And California has done some really interesting, smart policies, and now people in California die at a 40% lower rate from guns than elsewhere in the country. And so hats off to Californians. Jenny, this JAMA study, it looked not only at child mortality, child morbidity, it looked at mental health and the deterioration in mental health, also at the gaps in mental health between American kids and kids abroad. And those are just searing. Can you this is your field of expertise. And so can you talk a little bit about, again, why this deterioration happened? To what extent is this a cyclical issue that may be related to the pandemic? And to what extent this is just a broader secular trend that we have to confront?
Yeah, the worsening it's both children and teens. We mostly focus on teens, but the availability of those safe, stable, nurturing environments early on are part of what lead to teenagers and young adults who are struggling with their mental health. So the trends are very worrisome. I don't think it's just the pandemic. I think there was already a rise happening before the pandemic. And the point I want to make is that there's lots of debate about how tech has driven this rise in mental health, or is it other social and structural factors? It's not an and/or issue. They're so interwoven with each other. And during the past few decades, as there's been more economic stresses and disinvestment in the structures and circles of care that really help children thrive, there's been an amassing of power and capital within the tech industry that is occupying way more of kids' time and space. And so there's more evidence that when families don't have access to childcare, they watch more YouTube. Their kids watch more YouTube. When kids don't have access to quality after-school programming that's free and that parents trust, they sit and play video games all day because that is a safe place, or the parents feel like it's safer than having them out in the community. There's evidence that the price of childcare has risen faster than the overall consumer price index. So we have families that cannot afford to do all the things that help children thrive, feel purpose, regulate their bodies, sleep enough at night. And what's really concerned us, and so I was chair of the Council on Communications and Media at the American Academy of Pediatrics that just put out a policy statement in January where we talk about this is not just a screen time issue. This is a digital ecosystem issue where tech that has been exploiting time and attention is filling all these spaces that have been kind of hollowed out by a lack of investment in what families need. So we called for not just, we need more design that respects users' time and attention and ability to sleep and get out and move your bodies and read some books, but also we need investment in child care, parental leave, all the things that Secretary Clinton mentioned yesterday, and third spaces for teens where they can go out and be in the community and be with people and find that sense of purpose and belonging that they're searching for online.
Luke, you, like Jenny, are a scholar at the University of Michigan, but you're also in practice. One of the things I've known you for many years, one of the things I really admire about you is the degree to which you have put your scholarship to practice. We've talked a little bit about the refundable child tax credits that President Biden instituted that for 1 year dropped the child poverty rate by about half around the country. You know, that happened as much because of Luke's work as because of anybody else in the country. It was an extraordinary achievement. And you're now working on something called RX Kids, which has been adopted around Michigan to improve prenatal and early childhood outcomes. And I encourage you to look up RX Kids. It's an extraordinary program. But Luke, let me ask you a sort of uncomfortable question that relates to a little bit. So when we as advocates talk about these issues, we talk about the overwhelming evidence for early childhood programs, preschool, abecedarian, we go through the ranks. What we don't talk about is the pretty good Tennessee study that came out a few years ago that showed that pre-K did not actually improve outcomes because it doesn't fit our narrative. And when we talk about child allowances, like those that reduce child poverty in half in the US, we don't talk about a pretty good study that came out last year that showed that child allowances, in fact, did not improve outcomes over a number of years in ways that the authors of this study expected, that we all studied. And you know, if that had gone the way everybody expected, we would have pounced on that study. And so I want to ask you how we should think about these studies that seem well-designed, that don't fit into our narrative. And I just want you to reassure me, I guess, that we're all on the right track.
Yeah, it's such a great question. So as a scholar, I believe in looking at the weight of the evidence and trying to understand what's going on. I've actually been, Nick, on the lookout for any intervention out there, any program that doesn't have a null finding or a negative finding. If we were going to sort of rule out any pre-K or mentoring, actually, we have lots of studies that show mentoring doesn't work. Healthcare, actually, we have lots of studies that show that access to medical insurance doesn't improve health. But we know, right, from the weight of the evidence when we put lots of the pieces together that these things matter. And we saw it in practice on a large scale with the expanded child tax credit, as you mentioned. So we followed what many other countries do all over the world, which is to say, hey, raising kids is expensive. And society has a reason to come along and support families in that work. And when we did that and we said we're going to provide all but the very highest income families with $250 per child, $300 for young childs because they're so expensive, diapers, then we saw, as you said, child poverty plummet to an all-time low, like dramatic change in poverty. But it wasn't just that. We saw food insecurity plummet to an all-time low. Fewest families reporting they couldn't put food on the table. We saw the mental health of parents improve. We saw actually the highest credit scores ever for families with children as they use some of that money to pay off debt and make smart investments. We have evidence of this all over the world too, and that's a lot of what RX Kids is built on. So when the expanded child tax credit was not renewed, I was despondent. I was sort of laying under my desk, depressed, and luckily I got a call from Dr. Mona, who helped turn the tide on the Flint water crisis, and wanted to take a lot of those insights in, and we co-designed this program that's now active in 38 different communities all over the state of Michigan, in Detroit, where I'm now working, but also the Upper Peninsula. And we're starting to see, again, replicated a lot of the positive impacts of providing, in this case, $1,500 one time during pregnancy, and then $500 a month for 6 months to a year, all over different types of data, types of outcomes. And so with any research, right, there's just very few or no cases where research is entirely one-sided on something. And I think you and I have to live in that uncomfortability. We have to decide, you know, we're going to look at the weight of the evidence and make our best decision. We're not going to just throw out a study. You know, I can tell you with the one you mentioned why it was a very small amount of money, why they sampled sort of differently. But we want to be learning together, and we do have to grapple with that study and think about what it means, but not throw out hundreds and hundreds of studies that suggest this is a smart kind of investment, just as I think preschool and investing in early childhood education is a smart investment.
And again, I do suggest you check out RX Kids. It'd be great to see it expand around California as well. Nadine, your work on ACEs, I always see it through the prism of my hometown, which is a rural community in Oregon that good jobs went away, meth arrived, and everything unraveled. And so at this point, more than a third of the kids on my old school bus are gone from drugs, alcohol, and suicide. And I think about that and how adults completely failed my schoolmates. And, you know, we ended up spending a ton of money incarcerating my friends, but not investing in their early traumas and their education, et cetera. And there are more programs now in my community and communities like that around the country. But it seems to me that in some ways, the ACEs may have increased, and that's partly because, you know, meth and fentanyl went through. It ravaged these communities. So many kids growing up in chaotic homes. A lot of girls growing up in homes with a mama's boyfriend or a stepbrother who is biologically unrelated, and they are vulnerable. And so I wonder how we see, to what extent, despite all that we have done in terms of social policy, is the backdrop this kind of rising tide of adverse childhood experiences that swamp so much of what we're doing?
One of the things that you just said jumped out at me, which is this: in spite of these very good programs. And when I, as a pediatrician in practice not far from here in Baby Hunters Point, I very much was focused on developing a clinical model for screening and figuring out which programs that I was going to connect our families to. And in my role as California Surgeon General, a real eye-opener for me was that it's not about any particular program, but it was what was required was a real public health approach to break that intergenerational transmission, right? So one of the things that we found, as I mentioned, was that despite all the data that shows early detection and early intervention improves outcomes, kids in California didn't have access to care until they already developed symptomatology, until they already had a diagnosis. And so one of the key things that we were able to do was change the policy in California to say kids have access to wraparound services and specialty mental health based on risk rather than based on harm. So today in California, a child with 4 more ACEs has access to the wraparound services that we know improves outcomes. And that could be many different approaches, but that is paid for by Medicaid. That type of systematic transition and how we approach support is the work that I'm trying to do now to spread across the U.S. And we are working with state health policy agencies in 6 different states right now, so that we can turn that tide to be able to do early detection and early intervention. And I'll just briefly say the thing that feels really important and exciting to me is that these are, even though I led this work in California. These are not all blue states, right? We're working in New York, Hawaii, California, but also Tennessee, Georgia, and Utah. The Utah legislature just passed funding to reimburse primary care providers for screening for adversity. So that type of transition, it really has to be a systems level transition.
We're running out of time. We're gonna turn into pumpkins soon. But Jenny, there's always been, gaps in how children are nurtured, and rich parents send their kids to rich schools, and they have all kinds of enrichment activities and so on. But now, in addition, we have a digital divide that seems sometimes to magnify those gaps. And talk a little bit about that. Is that true?
I mean, the digital divide is shifting in terms of, it's not about access anymore. It's often about, more use or lower quality content use. The term always makes me think in a deficit model, and I would prefer to think like that AAP policy statement in terms of there are multiple structural reasons why it is so hard for families to have access to all the other things other than media that their kids need to be healthy. But here's what I see in clinic and what the research shows too, is that when kids are spending all that extra time online, they are not doing a lot of the either embodied experiences that we need, like being in nature, flipping through a book, playing outside. We don't have the same autonomy to just sit and kind of ponder and think and play and have our minds take the lead rather than a feed or someone else's design shaping what we do next. And then it's also displacing the relational experiences that are just so core to child's mental health. And parents themselves, when they are stressed out, they are scrolling. They are using it as a mental checkout, as this me time, and then and then they feel guilty about it. So I think a healthier digital ecosystem would benefit relationships as well as just kids. And so what we see is when they're less, when parents don't have the bandwidth to be monitoring, the kids are at higher risk of exploitation and just going down a rabbit hole of negative content. And those are places where I've seen clinically too, where families, they were trying their best to be good parents around an ecosystem that is actively working against them.
Luke, last question. So we've covered a lot of pretty grim territory in this panel, but your job is to cheer us up. And it does seem to me that 25 years ago, we talked a lot about child policy, and we had hunches about what would work, but now we have randomized controlled trials. We know what works at what cost, more or less. So are these solvable problems? Can you reassure us that even if the terrain looks pretty grim, that we have a path forward?
These are absolutely solvable problems. And you can see examples all over the world where social policies have gone into place and kids do better. And we don't have to look that far back to the expanded child tax credit in my own field to see there's a different path forward. With RX Kids, I'm going to leave you with one piece of joy. So this is like the joy in my work life. I have my heart tie on because RX Kids is not just about money, it's about messaging. It's about wrapping families with love. And so all of the messaging when people receive the program is about, we love you, we're here for you, we want to be connected. And the single thing that communities have to do to join into RX Kids is to agree to host a baby parade. And so they're going to be baby parades all over the state of Michigan. We're active in the entire Upper Peninsula. We're going to have one down Woodward in the city of Detroit. And I remember John DeMoose, he's a Republican from the Upper Peninsula, most rural part. His name is John DeMoose. It couldn't be more perfect, right, for a Republican from the Upper Peninsula. When we went in to talk with them, and we have half a dozen Republicans on the record supporting the program, and we asked him what did it. When he said he would support it, he said, "You had me at baby parades."
So folks, please join me in thanking these folks for their comments and for all the work they do. Thank you.